How many people do you have?
It depends on the session. Normally between like 500 and 1,000 people.
Do you know how many you have
Yeah.
today?
I can let you know once people start joining.
How many
Jeez.
people?
But we are live now. Hello, web shadowers. Good afternoon. Thank you all for attending our session. Today we have the pleasure of hosting Dr. Rajagopal, who will be teaching us about family medicine. As always, please remember that the Google form will be posted in the chat box and in the description of this video. And please stick around at the end for more information about our upcoming February roundups. With that being said, Dr. Rajagopal, you can get started whenever you're ready.
Okay. Hi, everyone. So it's kind of weird that I don't get to see all your faces. So I am talking to my screen itself. So usually I go by Dr. Raj. I am in primary care or family medicine. So those of you that are interested in what family medicine is, how it works is that when you go through your 4 year of medical school training, and then when you apply for your residency, I chose family medicine, and which is a 3 year program in the United States. But if you're a Canadian, it's a 2 year program. And the reason I chose family medicine is that I initially had interest both internal medicine because I wanted to be a hospitalist, but then I ended up going into family med because I liked women's health, a lot of the gyne procedures, especially the birth control, placing IUDs, doing pap smear. And I also liked pediatrics, the kids. And then I like the adult medicine, and I also like geriatric. So the only residency that actually take care of from pediatrics to older generation is family med. And you can subspecialize within family med if you wanted to. For example, if you're interested in delivering babies, that's an extra layer of specialty that you do within family med, but I opted out. You can also do sports medicine fellowship from here. So there's a lot of subspecialty you can do within family medicine. So I went into family med so I can pretty much take care of everyone from age 1 up until old age, pretty much. And I specialize in women's health itself. So that was the reason I didn't do internal medicine where I would have went into the hospital. This is more of an outpatient setup. So you work in an office setting, and I work 4 days a week. I am full time, even though I'm 4 days a week because I do 10-hour shift a day. So Mondays are my off days. I work from Tuesday to Friday. So in family medicine, so that's how you get to it. But what other things you would see in family medicine is the way I look at it, we are the first form of physicians that are coming in when patients have any concern. So it could be very simple viral infection or sinus infection or headache to where you talk leading to more chronic medical problems, right? For example, diabetes, treating blood pressures, COPD, asthma, heart failures, all of that stuff. Then you do a lot of counseling. So smoking, alcohol, weight loss counseling. You can do various kind of counseling. And then you have mental health issues you're taking care of. So example, anxiety, depression, bipolar. I treat kids with ADHD, ADD, all of the mental health component. And then, of course, I have the women's health where I do routine cervical cancer screenings, HPV vaccines, starting people on birth control, putting IUDs as a form of contraception, and depot shots. So this is just a variation of what I do in a day. So I would have mix of patients from my morning till the end. And if some of you are interested in procedure within family medicine, there's all kind of procedures you can do. For example, putting contraception like IUDs or Nexplanon that we put on the arms. These are considered procedures. We can also do skin procedures where you take out the molds or you take biopsy of suspicious skin lesions. We also take care of simple stitches or we take out the sutures. There's a lot more you can do. If you're interested in sports medicine, a lot of us also do injection. So patients having chronic pain, we do steroid injections for the back, the arm, the knees, you name it, pretty much a lot. There are some family doctors who also do Botox injections, not just for cosmetic, but also for treatment of migraines and headaches. So your option in family medicine, it's pretty much endless, and you choose how you want to narrow down or be more broad as you go. So Botox injections is something I may want to add on to my list later on. And I also enjoy skincare. So that's something I'm thinking of expanding as one of my specialty as I go. Because I just graduated 1 year ago. So I just finished being a family medicine doctor almost 1 year. So there's a lot more I can do. And especially women who wants to have a specific schedule, so you're not always on call, things like that. Family medicine suits you very well. You can, when you deal with your contract, you work with your employee to find out the days you want to work, the number of hours you want to work, so you're not compromising your full-time status, but also fits your lifestyle. Because I'm a mom, I have a 2-year-old son, so I really wanted to make sure my time with him is not compromised. So I work the time he's in daycare, and then when I'm done work, I pick him up from daycare, and it's my time with him. Um, so that was one of the major reasons I opted out of being hospitalized. So one other question, how can you expand your specialties? Where can you go to continue that education? Yeah. So every year, as we are practicing, we have continued medical education called CME that we have to keep up to make sure we're keeping on track of what are the new guidelines that are coming in, how we are practicing, things like that. So it's a separate course that you probably have to take on your own time. Especially I only work 4 days a week. I have Monday and the weekends off. So if I decide to do a Botox injections and I want to specialize it, that's a course I would take. And it's an exam you would have to write, and then you have to prove that you can do it. And then you're pretty much licensed to do it in your practice. So depending on what you want to specialize, you just go ahead and you have to look up on your own the courses. You have to pay out of your pocket for the training. But some employees might pay for you because that's an additional layer you're adding onto your resume, right? So that will bring more patients to your clinic, especially when I'm thinking about Botox, and also specializing in face skincare, especially with injections and things like that. That pretty much brings a lot of female clients into my office. So there are ways of doing it. You just have to do your research and look into it. And AAFP, which is our main resource for family medicine, they have many different CME that they offer throughout the year that you can sign up. And your employee pays you, depending on how your contract is, they pay you yearly to go for these CMEs. So it's just paid. Sometimes it's paid, sometimes you have to pay a little out of your pocket for the exams and stuff, but it's doable. So that's in a gist of what family medicine is. I'll give you a little bit of background of my med school experience before I get into the case that I want to really talk to you guys about. So I am a Canadian myself. Um, I actually tried to get into a Canadian medical school, but I didn't. I was listed. I got interviewed, but I got shortlisted, but I never got accepted. So back when me and my husband were both looking in terms of coming into the States, as a Canadian, obviously we are going to be on a visa. So we were looking at medical school in the States as well as the Caribbean. So we opted for both of us to go into a Caribbean medical school. So that's where we did our med school training. So the way the Caribbean med school works, I'll give a quick brief, is that you spend almost 1 to 2 years on the island where you do your theory part. And then your clinical rotations will be all in the state. So both my husband and I traveled pretty much across the state, down south, up pretty much everywhere. We've been in Atlanta, Augusta, Georgia, all the way to Chicago and Michigan to do our clinical rotations. You do write the same exams as the US medical students, which is your USMLE Step 1, Step 2, which has two components, the theory and the clinical component. So we wrote all the same exams and then you go in. Can you hear me better? I just increased the volume. I think my phone was right next to it.
Yeah, your sound is just a little fuzzy. I wasn't sure if anything like is covering up your mic.
I did. I have my cell phone and I was getting text.
Gotcha. It does sound a little clearer now.
Okay.
It's okay. Don't worry about it.
Okay.
If nothing's coming out, it's no worries.
So I forgot what I was saying. So I think I was saying about the exams, and then you go into your residency match. And when you're going for the match, you are competing against the US medical students, right? Because you are considered an international medical graduate because you didn't do the school in the States. Plus, I'm a Canadian. So there's two factors that plays into the role. So it's a risky. But if you have done well in your standardized exams and you have really good reference letter that are coming from the directors of different programs, your chances of getting a good interview is pretty high. Both me and my husband, we were couples matching. So we did have about 22 interviews together. We actually had more, but we stopped after the 22 because we got up to 30. We just couldn't do all of them because there's a travel expense associated with it. And then we did both internal and family medicine residency interviews. But then when we ranked, our top three was family med. And then we both did end up couples match into our first choice of family medicine. So it is doable for those are looking at med schools outside of the US and Canada. And then I told you guys about, what did that say? My residency was in Washington Hospital in PA. That was for 3 years. Question. Is it hard to get a job once you have specialized using the external courses you are describing since you're competing with specialists in those areas? For specialization than internal medicine. Okay, so I don't know if you misunderstood. When I see you're specializing from your regular description of family medicine, you're really not competing. You're making yourself more competitive. Do you know what I mean? Because you're enhancing your practice, right? If you're working in an outpatient setting, the more you're able to do, the more patients are you going to be able to have. For example, me, I am actually one of the female physicians in my building. against what, there's one, two, three, four male doctors. So I am one of them. I'm pretty much the one that do a lot of women's health. So a lot of the female patients wants to see me because they're comfortable. Obviously, females are more comfortable with their gyne care when they have a female physician compared to a male doctor. So there's a pretty much a high demand for all the female populations that wants to see me. So which is a bonus for me, right? So it's not hard. The more you specialize, it just helps you. It's an added bonus, especially if you decided to leave this practice and you want to go somewhere else, it will definitely help you. Is family medicine less flexible for specialization than internal medicine? It depends on what you're trying to specialize. Because internal medicine, it's really, you go in internal med and then you're specializing in much more a specific a role. For example, GI, gastroenterology, cardiology, or pediatric cardiology. Like your specialization becomes more focused. So that's how I look at internal medicine. Within family med, you're expanding your resources. You're doing OB, or you're doing more gyne, or you're doing sports medicine. You can even add a layer of palliative into it, geriatrics into it. These are different fellowships that you can add after you finish your family medicine. If you decided to do palliative, so that's the end of care life, and hospice kind of care, that's a 1 year extra fellowship for you. Geriatrics, which is for elder care, that's an extra 1 year of specialization. Sports med, it's also 1 to 2 years. And OB, same thing, you would do 1 to 2 years where you do more deliveries. So you are up par in terms of wherever you go, you're comfortable delivering even complicated OB cases. I hope that explained it. Could you explain more about what couples matching is? Yeah. So couples matching is pretty much when me and my husband, well, we were married before we went into med school. So we were as a couple in med school. So when we decided to apply for residency, when we say couples match, your how do I say, your application process, you are stating it, you're applying as a couple. So when you're listing your programs based on your choices, my list also matches my husband because we're trying to get into the same residency together. In case I didn't, then they will try to combine us so that we're in the same city or the same region. Do you know what I mean? So it is not an easy process, like in terms of sitting down. It's a lot of calculated things you have to do when it comes to residency. We spend hours and hours after the interview listing our programs so they align with each other. So there's no mistake on our end because when the match is happening, it's all computer that's picking and matching us together. Do you know what I mean? But knock on wood, but God grace, we both got into the same program because that was our first choice, and then we got matched together. So we ended up into the same program and we finished the same residency 3 years after. So I hope that clarifies what couples matches. Any other questions before I go into the case for today? Shall I go on? What are the hours like being in family med? Yeah, like I said, that's the days you want to work, the hours you want to work is it's up to you and the employee that you decide to go work for. I was very sure when I was looking for jobs, how many days I wanted to work. I only wanted to do 4 days a week. I wanted to have a day off. And then since you want to be full time, I have to do it with 10 hours. So I'm 40 hours per week as per the calendar, right? So I'm Tuesdays to Fridays, and my husband works from Monday to Thursday. So he has Friday off, and we both work in the same clinic together. And my first patient starts at 7:45, and my last patient is at 3:45. So I get the buffer at the end to finish things up with my notes, and I'm out the clinic by 4:30, so I can pick up my son at the daycare. Then I come home. So that's my schedule. And the reason I have made it that way, I also skip lunch. So I always have patients during my lunch so I can finish by 5:30. Because I get like you will have time in between while I'm dictating my notes. I can eat my lunch quickly, but sometimes if I'm busy, I may not be able to eat lunch. But so far, it's been good. I've been able to work it out, but that's my schedule. Can you do family medicine, then do a fellowship in oncology, or is oncology through internal medicine? Yeah. So oncology is specialization on its own. So you do internal medicine, and then you apply for oncology, and then you go into its own specialization. I think it's about 3 to 4 years, if I'm correct. So that's different. If you're a family medicine physician, do you have to be board certified for each practice aspect like pediatric? No. So when you are board certified as a family medicine doctor, you are eligible to treat so from newborn all the way to elderly. It doesn't, you don't need to have any special certification for pediatrics or gyne unless you're doing OB. Like if you're doing deliveries, you have to have a sub specialization proving that you have done enough deliveries to be certified, and you have to yearly prove that. So that's the only one that's different. How did you feel like the quality of your medical training compared to your peers who went to school in the US? Okay, that's a good question. So, a lot of people think just because you went to the Caribbean Medical School, your training is poor. Like I said, only your theory is done in the Caribbean, right? But at the end of the day, you're sitting down and writing the same board exams, and you're both certified based on that, not really the training. But the clinical training, I'm getting them in the States just like my US colleagues. So we all get trainings. And personally, um, for someone who went to a US medical school, let's say in one particular state, they only get the rotation in that hospital. But me, I have done clinical rotation various different states, and I have some of the best of best training. They're not easy on you. They're really hardcore training. But I really enjoyed the hospital medicine, but because maybe I had a personal interest, I learned a lot more, and I was very comfortable. So when I went into my residency, I was actually one of the best residents when it came to the internal medicine. I enjoyed it. I loved it. I loved the thrill of being in the hospital. So I did not feel like I was any different or less trained compared to some other residents that came from the US schools, either the DO or ND schools. I did not feel any different. But if you slack off, right, during your training and you think it's an easy go, you will suffer during your residency and it can show. So it's a hit or miss. But I definitely had best training, and I was able to bring that onto the table when it came to my residency. Any other questions? Mm,
I think you can go to the cases now if you would like.
Perfect. So one of the key things that we treat in family medicine is diabetes. Um, Obviously, I can't see all of you, but I'm sure you all have or heard of somebody that have diabetes, like in your family or in your friends. It's very, very common, especially in the States. So when we talk about diabetes, you can subcategorize them as type 1, there's type 2, and there's gestational diabetes. I actually have done a video on my Instagram describing the three, but very briefly, what type 2 diabetes is that your body has an insulin resistance, which means it is not picking up the glucose molecule in the blood. As a result, the amount of glucose pretty much rises because it's unable to pick them up and store them into the cells, right? And this is what leads to type 2 diabetes. There's over 30 million people in the US are diagnosed with type 2. And how do we go about telling or diagnosing somebody that you have type 2? It's a very simple blood work. It's called A1C. Um, you do this blood work every 3 months because the number you measure, it's not just at that time, it is measuring over a 3 month period of time. So because it's measuring the glucose molecule that are glycated around the hemoglobin, and you know the hemoglobin can last up to, the red blood cells can last up to 90 days and then they re-begin the new storage. So that's why this A1C marker is good for 3 months. When we measure it and it's greater than 6.5, it's a percentage, they are automatically considered diabetes. If they're less than 6.5 but greater than 5.7, they're in the pre-diabetic, right? So you diagnose somebody with diabetes, but they can be right before that. They're in that borderline, that's what we call it, pre-diabetic. There's over 80 million people that actually have pre-diabetic. So I really want to focus on type 2. But what gestational diabetes means, it's the pregnancy that's developed during pregnancy. I personally had gestational diabetes and ended up on insulin in my third trimester, which was not fun. And type 1 is when your body does not have the insulin. So it's an autoimmune disease. So your body is producing antibodies to destroy the insulin you have. So you automatically need to be on insulin with type 1. These are the people that usually have an insulin pump and they are continuously monitoring their blood glucose level. Type 2 can end up being type 1 over time if they don't control it because their insulin can be pretty much depleted and they can become insulin dependent. Do we have any question about A1C or what type 2 means? So type 2 can be worse than type 1 if it's uncontrolled, right? When you don't take good care of your diabetes, it can affect you head to toe. So the complications, you can stroke out, you can have a heart attack, you can lose your vision, you can lose your senses, the tip of the fingers and the tip of your feet, the numbness, the tingling. You can have a lot of peripheral vascular disease where your smaller arteries are starting to become occluded. Men usually have issues with sexual intercourse because they will start to develop erectile dysfunction. So literally head to toe, your kidneys will start to shut down. They will have issues going to the bathroom. It can affect your entire lifestyle and you will become dependent on insulin for lifelong and then you can easily die from it if you don't take care of it. Can you explain again what A1C is? Yeah. So A1C is a marker that you test by blood work. And that's what determines, the number determines if a patient is diabetic or not. And 6.5 is the cutoff we look for in the state. So if anybody's number is 6.5 or greater, they're automatically diagnosed with diabetes. The A1C, it's basically it's measuring the glucose molecule that are wrapped around the hemoglobin. We call it glycolated hemoglobin molecules, right? So hemoglobins pretty much, it's your RBCs that's carrying your oxygen. They have a life up to 90 days. So that's why we say this test is good for 3 months. We repeat every 3 months to see how well they are improving with the treatments we put them on. Among what age group are type 1 versus type 2? So type 2 usually happens later on. So you can develop type 2 if you have some of the risk factors that I'm about to go through in your mid 40s and on. But if you have risk factors, because I have patients in their 30s, but they are morbidly obese and they have diabetes early on. So it depends on the risk factors, but really it's later on in life, starting in your 30s and up. Type 1 can happen when you're really young. Like a lot of pediatric diabetes are type 1. So there's an age also. So if you understand the mechanism, you can pretty much understand the age group. So some of the risk factors for diabetes is the obesity. Just like diabetes, obesity is like pretty much the number one killer in US. Every single patient I see on every single day, their BMIs are greater than 30, right? Body mass index. And you're measuring this number based on your weight per kilogram over your height per meter squared. When you calculate, you can Google a BMI calculator. You can put in your weight and your height, it will give you a BMI. A healthy range of BMI is around 25. And when you're over 30, that's considered obesity. And even in obesity, there are different classes. There's class 1, 2, and 3. And that's when you know your BMI is in the 40s, the 50s, and 60s. I even have a patient with a BMI of 80. So obesity is the key risk factor for diabetes. Family history. So if your mom or your dad or your siblings has diabetes, there's a high chance you do. So my mom has a history of diabetes, and that was the reason I had gestational diabetes when I was pregnant, because I'm not overweight or in the obese category. But obviously, pregnancy hormones can play a role, but the genetics played much more role in my diagnosis. Ethnicity, African American, South Asians like us, Hispanics are more prone to having diabetic because their diet is also very, very different. Like in my culture, we eat a lot of rice. Same thing with African Americans, Mexican, they all eat a lot of rice, the pasta, the pita breads, all of that is high carb. Women are more than men. PCOS is what it's termed for polycystic ovarian syndrome. So women that are diagnosed with PCOS, where you have multiple cysts in your ovaries, they are automatically will have diabetes down the lane, especially if they have the obesity in their risk factors, and gestational diabetes. These are all risk factors. So the fact I had gestational diabetes and I have a strong family history, regardless of how much I weigh, I am already at a risk for developing diabetes later on as I get older. So that's more important for me to be more proactive about keeping my weight in the healthy range and eat better and be conscious of what I'm eating. So those are the risk factors. So when I see screening, you're going back to the A1C, right? Normally we start the screening around the age 45, but if I see any of the risk factors I just described to you in the previous slide, I would usually ignore the age and go for the testing, because I have had patients with their BMI in the 40s and 50s, but they were less than 45, and I have screened them and they had positive A1C that's conclusive of diabetic. So I always look at the risk factors and give more importance to that. Symptoms. So when a patient is diabetic, right, they don't know they have it, but they will come to you and they will give you these three classic symptoms. They would say, Doc, I don't know, all of a sudden I have to pee a lot. I don't know why. I know I drink water, but this is just weird. I'm just going to the bathroom more often. I'm drinking water, but I'm still thirsty. I feel like I need to drink more. Those two, I hear it very, very often. And the weight gain. You will see weight gain a lot with type 1, but you can also see with type 2 diabetic. They will say, all of a sudden, I don't know what happened. I'm trying to lose the weight, but I'm not. I gained so much of weight. Like, what's going on? These three are really the big red flags for me to consider them to screen for diabetic, even if they didn't have the risk factor or the screening age. I will use that as a reason to screen them. So to have a diagnosis, my best go-to is the A1C, because it's not just looking at that day, rather for the last 3 months in your blood, it's measuring where your A1C is. But we can also do a fasting blood glucose. What that means is that you don't eat anything after your supper. So you're fasting, and the next morning, first thing you do, you go do a blood work. And then if the fasting blood glucose is greater than 126, that's a pretty good indication you're diabetic. And let's say on a random blood test, if I see your sugar is over 200, that also gives me a red flag. So either I will repeat that test again, and if it's for the second time, if it's greater than 200, that's pretty definitive you're diabetic. Or I can confirm it with an A1C and then make a diagnosis. So any three of them are okay to do, but the more conclusive one is the A1C. Any questions so far about the screening? That's a very good question. So can someone get rid of diabetes, or is it a lifelong problem once you have it? No, you can get rid of it, because when I talk about the treatment, the first two is what really makes your diabetic under control, right? So if you really bring your weight under a very healthy range, and then you exercise regularly and you control your diet, you can get rid of diabetes. Like, do you know what I mean? You can't fully get rid of it, but you can come off of your diabetic meds and just watch how things are going closely. So it is possible to get rid of it. And that's something I pay a close attention to, especially my young patients. I don't want them to be on a medication for a long term, especially if the weight is what's contributing to their biggest challenge. So I will work with them in bringing their weight down, and also their diabetes under control. So is ethnicity a risk factor only because of the lifestyle, traditional food, or do genetic differences between ethnicities play a role too? Genetics, absolutely, plays a huge role, but at the same time, there is the diet the traditional diet that plays a role? So it's a combination of two. That's a good question. If a patient has all the symptoms but not shown to be diabetic through test, what else it could be? Well, if you're having those symptoms but you're not diabetic, we have to look at other options. So this is pretty vague of a question, but I need to really look at the patient's history and do a full exam and see what else is going on. Are they having UTI? Is that why they're going to the bathroom more often? Is there STD that I need to worry about? Are they gaining weight or losing weight? Like there's a lot of factors I need to look into if they're not diabetic. But most of the time, if they have those symptoms and they have the risk factors, majority of the time they will be diabetic. But if not, then that's not the end of it, right? You have to look for other options, and that's why the differential diagnosis come into play. How do you respectfully approach the subject of weight gain? Yeah, it's tough because some people don't like to be told in their face you're overweight or you're obese. So the way I look at it, obesity is a medical problem, and just like diabetes, I'm treating them for diabetes. Obesity can also be treated, right? Nobody wants to be overweight or obese because it has a lot of comorbidities associated with it. So me as a physician, I always ask, how do they want to be approached? Are you happy with the way you are? Do you want me to help you as far as losing the weight? Because the way you are right now, if I do the test, most likely you probably be diabetic. So do you want to be on treatment for diabetic, or treat the main problem that is your weight and let me help you bring that weight down and get rid of all the other issues you're having? For example, your depression, your diabetes, or your blood pressure, right? All of that can be treated with just losing the weight. And there are weight loss medications that we can put patients on and help them bring those weight. So you have to be, it's a sensitive topic, but you have to put it out on the table. As a physician, I'm there to help them. I'm not really there to like bring them down, say, you're fat, you don't look good. That's not my job. My job is to make them feel better about their body and mind. Both matters to me. So it really, the way you talk to the patients matter. Okay? So going on to treatment, diet is really, really key. I will admit, a lot of us as physicians, through our training, we don't get a lot of nutritional training. So it was really hard for us to be able to sit and talk to our patients on how to do the diet. But I did a course in nutrition because I love nutrition. And some of my patients cannot afford to have a dietitian or nutritionist because they have to pay out of pocket. So I want to be able to help them start the journey when I tell them they're diabetic. So diet plays a huge role. And instead of trying to change on how their diet they need to do, the way I do, I sit down and I ask them, what do they eat for breakfast, their lunch, or their dinner? Because depending on their culture and their tradition, their diet is very different. And I know that because I come from a Sri Lankan culture and I know what we eat on a daily basis, like what my mom eats. I know it's very different from what I eat. So I can relate and I can understand. So I usually analyze what they eat and I try to modify little changes at a time. Because if I try to change everything at once, they just become so overwhelmed and they're like, I'm not doing this is too much for me, and they walk away from it. And that's not the whole point of the treatment. So when I know what their diet is, I try to modify. Because a lot of my patients are soda drinkers, right? They drink a lot of sodas. And that is a lot of carbs. If you take, doesn't matter, they say I drink a Diet Coke. to me doesn't matter. It's a Coke is a Coke, and Pepsi is a Pepsi. It's a soda. When you turn around and you look at the label, I care about the total carb that drink has. And if you're drinking 4 to 5 a day, you can imagine the amount of carbs they're putting into them in a whole month and how much money they're spending. So that's where I start in terms of cutting. So I would say, can you cut down? I won't say stop. I would say, how many are you willing to cut down in a day? So if you're having five, can you maybe do two a day? So I will slowly taper it because tapering is more effective than cutting. I cut, they may do it for a week or two, they're going to bounce back and go back to drinking the same. So it doesn't work. So once they taper, they start to lose that taste. Whatever that was making them crave, they will start to come out of it. Then I will start to replace that with water. Or if it's the fizzness that they really like the soda, remember when you open it up and you drink it, that thirst, the fizz, is that some people crave for. Then I would substitute that for a fizz water. You can buy the soda stream for $45 and you can make your water into a fizz water and still have the same craving, but 0 calories, 0 carb. And that's a big change I made in their diet. So that's how the diet really works. And then I also sit down in terms of portion controls, right? So depending on what they're eating, I will try to substitute, for example, white rice for brown rice, or you can do more oats, or you could do different kind of grains instead of the rice, the cauliflower rice. And then you portion control. So you have to teach them, if I eat a cup, which is like the size of your palm, how much carb is that? Especially if your diabetes really out of control, I really have to focus on how much carb they can have for your breakfast, your lunch, and dinner. So they start to count of their carb. Carb counting comes into place, and they patients are clueless about this. So these are simple things I have to sit down and teach them at multiple visits. Exercise is really, really important. When I say exercise, some of my patients say, I can't afford it. I can't afford a gym. I can't afford a gym membership. That's way too much. You don't have to. That's not what I'm going at. Why don't you get up and walk, right? If the weather is nice, you can, even if it's in winter, I know winter is hard with the weather, but I still see people that are suit up every day when I drive to work. They're walking 1 to 2 miles a day. You can do that when the weather is nice in the spring, the fall, and the summer. Even if you give me an excuse for winter, you can make up for the rest of the year. Simple walking, at least 30 minutes a day, will make a huge difference. If you have stairs at your home, go up and down the stairs and get the 10,000 steps throughout the day. Just don't do it all day and have problems with your knees, but try to get that 10,000 steps a day. For some people, getting a Fitbit really helps in terms of keeping them motivated. Um, and also drink a lot of water, because these diabetic people, like I said, they are peeing a lot because they have a high sugar in their blood, which makes them pee a lot, so they're thirsty. So keep up with the hydration, exercise, and keep up with your diet. If two of these doesn't work, depending on how severe their diabetes is, I do need to start them on medications. So there are pills and there are insulin. A lot of patients don't want to go on insulin because it is painful, right? You're giving yourself injection, maybe not once a day. Some will have to give them 4 times a day, depending on their sugars. When people are giving insulin, they have to monitor their glucose level 4 times a day. That means they have to prick their fingers 4 times a day. It's not easy, trust me. When I was pregnant, they asked me to do it and I refused because it was so painful. But when you're young and you're always trying to learn things, I figured out there was so many different glucometers that you can buy. It's like a sensor that you put on your arm so you don't have to prick. And it's a scanner, you just scan it. I don't know if you guys heard about it. It's called the Freestyle Libra. Some insurance covers it, some you have to pay out of pocket, but that was worth the money for me during pregnancy. So I did not have to prick myself. But when patients are morbidly obese, that kind of sensor will not work because the nano needle, it's not really getting into the skin, right? It's getting into the fat tissue. So it may not be a good sensor. But they are coming up with various different meters, which are beneficial for younger patients that are diagnosed with either gestational diabetes like me, or not on the obese side, we can still use them. So I try to minimize the insulin before I maximize the pills. There's so many different pills. The common one you guys have heard of is the metformin. It's actually the first oral medication. It's the cheapest, and there's no other meds that has come up shown to be as effective as metformin. But one of the problem with metformin, they get a lot of GI side effects. So nausea, the vomiting, the diarrhea. So it's really hard to go up on the dose if they're having those GI side effects. So you have to start slow and titrate them up. So I can go on another hour of talking about all the different oral medications, but I'm going to save it for another time. But like I said, medications is needed when the first two fail. So I usually try to see, give my patients some time and repeat my A1C. If it's not working, then medication is needed. And I play this by how compliant the patient is, how well I trust them, how is my communication with them, and then I make my decision. And obviously the decisions I make, it's a mutual. So we're always in an understanding of what we are going to do. So now after this slide, I'm going to actually give you a patient case. But do you have any questions up to this point? I know. Oh my God. The insulin cost, it's like shoot me. This is something I deal with on a daily basis with my patients and the insurance company. How much stress affect diabetes? Stress absolutely affect your glucose level. The higher the stress, the higher your blood glucose level, and the more uncontrolled your diabetes will become. So that's another factor. So that's what I say. When I prescribe a patient insulin, there's an added cost, right? They need the pens, they need the needles, they need to have the lancets and the needles to check their glucose. They need the meter. All of these are added costs that could be like 500 or even more on top of the insulin that they have to pay. It is it's very expensive. Depending on the insurance they have, insurance will only cover certain insulin. So I'm really stuck with the kind of insulins I can choose. But usually when they tell me this is the only insulin we will give for this insurance, they will cover the cost of all the other stuff. The meter, the lancets, the needles, all of that stuff. But that's why I stay away from insulin, but sometimes I don't have a choice. I have to, and that's a cost. I have to bite my tongue and go with it. And even then, I'm playing with the insurance to figure out the minimum amount of money my patient have to pay and be able to take it. The other reason I'm not a fan of insulin does cause weight gain, right? And weight gain is already a problem in these diabetic patients, and I'm not helping by giving more insulin. When you get insulin, you're hungry. Like when I gave my insulin during pregnancy, yeah, I was pregnant, I was hormonal, I was hungry, but insulin made me hungry. I was like, oh my goodness, what is this? And I can only imagine my patients taking these insulin 3 to 4 times a day. And why is it causing the weight gain? It does cause weight gain, and that's one reason I don't like it. Insulin will be my last choice if I have to, but sometimes, like I said, I don't have a choice because some of the other meds are also expensive. There are new diabetic meds that work much better, especially with weight loss and diabetes. They work top notch, but they're way expensive. I'm sure you guys heard of the name Victoza. It's one of the best medications out there for weight loss and type 2 diabetes, but out of cost is $1,000 for one box. No one is going to pay that much money, but it works like it's like miracle pill, but not a lot of insurance covers it. Some of my patients are able to, and I'm lucky they are, because I'm seeing result with diabetes and their weight. So it's a give or take. That's a problem with US and the medical cost of the drugs. I also have patients that cross the border to the Canadian side and they get insulin there because it's cheaper. Any other questions? Okay. If you do, hold on to it. Let me start the patient case. Okay, so this is a patient that came to me back in March. She was a 49-year-old female. Her past her past medical history was hypertension, meaning high blood pressure. She had anxiety, and she also had lower extremity edema, meaning her both her lower legs were always swollen, and she had obesity. So she was seeing a nurse practitioner at a different location. And she actually works as one of my nurses within our building, right? She works in my building. So she heard that I was a new doctor and I was a female doctor. So she wanted to switch and came to me as a new patient. And this is what she presented. And on her meds, she was taking hydrochlorothiazide and Lasix. Both of them are water pill. They're given for blood pressure, but also to take fluid off of your legs or your heart, like for heart failure. And Celexa is the medication she was taking for her anxiety. Like I said, she's a nurse. She denied any smoking or alcohol. She was married. She has no kids. So, given this, let's say you're the doctor. She's coming to you, and this is what you see. Given what are the risk factors for me to screen her for diabetes? Anyone want to go for it? Obesity and hypertension, yeah. One of the things that was really surprising to me is her former physician never screened her for diabetes. To me, when I saw her, even before I looked at her history, because I'm seeing her as a person, I was like, you need to be screened because she was morbidly obese. Okay? Her on her exam, so when you do an exam, right, you have your vital signs. So your vital signs will include your weight, your height. They will take both of them and calculate your BMI. Her BMI was 57. And then you have the blood pressure, the respiratory rate, and your O2 saturations. For her, all her vitals looked stable, her blood pressure, her respiratory, all of that. And then going down the physical exam itself, like head to toe, you first want to make sure the patient is like alert and oriented, right? Whatever you're talking to them, they understand, they can comprehend, and they can repeat to you, which is really important. Because sometimes I can talk to patients, but doesn't mean they really understand. She was very alert, she was very oriented, she was very sweet lady. Her heart was normal. She had normal heart sounds S1, S2. I did not hear any murmurs. I did not hear any rales or bronchi in her lungs, which could be an indication she may have fluid in her lungs or she might have wheezing. Everything looked normal. Her legs, on the other hand, did have 2 plus pitting edema. So there's edema and there's pitting edema. So when you press on the legs along the bone, like tibia bone, if they make a dimple and it takes time for that to come out, that's pitting edema. When you push, it goes and comes out, that's just edema. She had pitting edema both her legs below the knee all the way to her feet. Her labs, pretty much everything looked normal, like her kidney function, her hemoglobin, her electrolytes, the sodium, the potassium, the key things I'm looking for, they all looked normal. But look at her A1C. Her A1C came back at 11.9. So what did I say the A1C for diagnosing someone with type 2 diabetes? Where do you think she stands on the scale? Is she starting diabetic, moderate, or severe? Tell me. Right? She's almost close to 12. That's double um, where you are starting, 6.5. So she was considered type 2 diabetic, severe. But what is going to determine that severity is she complicated or uncomplicated? Right now, she wasn't showing any symptoms of like vision loss, chest pain, low urine output, numbness or tingling in her fingers or feet. None of those symptoms she was showing. So she wasn't complicated, but she could get there if I leave her A1C at 11.9. But she was a very compliant patient, right? So the first time I saw her, I did the lab work. I brought her back because I didn't feel comfortable telling her she was diagnosed with diabetes on the phone. And this was March. So this was right before, like beginning of March, the pandemic was hitting us. And then we were going to switch to televisit. So I had the time to bring her into my office and sit down and tell her, hey, these are the results. This is what it means. Now, what do you think? I wanted to see her so I can see how she's processing. A lot of the time, when we give these news, they are shocked as hell. They're shocked and they're in denial. A lot of patients don't want to accept the truth. So I really wanted to see her in person so I can see that. And she was in denial in the beginning. She was in shock. She was shocked that her former doctors never diagnosed her. Someone should have, but somewhere down the lane they missed it because you don't come to 11.9 just like that, and you don't get to a BMI of 57 like that. It was gradually happening. This should have been caught early and helped, but it didn't. So I'm seeing her. It took us time. So me and her really needed to see more often to make sure that she's overcoming the denial, she's overcoming the shock. She's taking the time to understand the diagnosis and what the next step is. So I have to take baby steps with her, and I was seeing her almost every 3 months. And because of the COVID happens, I was doing more frequent visits with her on the phone. Like I said, she was very compliant. Once she stood back and realized this was a big problem and she needed to take control of this diagnosis and the disease itself, we were both on the same page. So I literally spent about 20 to 30 minutes just diabetic diet, and she was willing to work with me as far as her diet, like really teach her where the carb is, how to carb count, how to portion control. And she got on a Fitbit, and then she followed me on Instagram because I'm crazy about fitness. She wanted that motivation to work with me. And then she started exercising, going out because March was into spring, so we were getting into the summer. So the weather was nice. She was willing to exercise, she was willing to work on her diet. So, but given that it's a high number, that's a number that I would usually put patients on insulin. But with her, I trusted her instinct and she was going to do the work I wanted her to do. I didn't do the insulin for her. I started her on metformin because for her, the issue was also, even though she's a nurse, not all the meds that I want is covered for her. So I did start with the cheapest medication, which was metformin. I did 500 once a day just to see if she's not developing any GI side effect. And I slowly titrated that metformin to 1,000 twice a day. So it's a 2,000 milligram a day is the maximum dose. And just maximizing the metformin, the diet, and the exercise, you can see how well she did. So she went from 11.9, she went to 8.7 in 3 months. In 6 months, so every 3 months I'm seeing her, 7.3. The recent visit I had her, she was still 7.2. She lost about 30 pounds for me over 6 to 9 months. Her BMI has gone from 57 to 53. That's a huge improvement. But I have noticed her weight kind of plateaued and her A1C also plateaued. And my goal for her A1C, because she's young, she's only 49, I want that A1C to be less than 6.5. So recently I added a new medication called Invokana. Invokana is a medication that it works in multiple different ways. It's not an injection, it's still a pill. She still refuses to do the insulin. So I'm trying to see all possible oral medications that won't cause her the weight gain but help me lower her weight and also her diabetes. So Invokana is one of those pills that will help her with her weight and it will also help her with diabetes. But the third bonus effect for her, it helps pull the fluid off of her legs. So she doesn't need to be on those other two meds that she was taking for her the lower extremity swelling. So the Invokana will do all three, and a fourth, it can also control her blood pressure. So literally, I have one med treating 4 different symptoms, but this medication is expensive. But her insurance was willing to cover for 30 days up to 90. I was like, she's one of those who's still complying with her diet and exercise. Even that 30 to 90 days, if that Invokana can pull some of the weight down, why not? So I gave it a go on the Invokana. The insurance covered it for her. Um, and I'm going to see her in 3 months, which is coming up soon. And I'm hoping to see some changes. If Invokana won't cover further on, but if she came to her A1C at goal, I'm okay taking it off, but keeping her on the metformin. And then I will keep a close eye to make sure she doesn't rebound back. But you can see for this patient, I didn't do insulin. I could have with her number, but I didn't. It's all about the patient's and the doctor relationship, honestly. If the patient is willing to work with you and they have a really good understanding of what is in front of them, a very good education on their diet, and motivating them to exercise and using the medication that they can able to afford worked just well for her. But it may not work for someone else, right? So it's just one patient to the other. It could differ. But for her, it worked, and I'm extremely proud of her for the amount of work she has done. And that's where we stand with her as of now. So that pretty much brings to the end of my talk. I think I kept it within an hour. So they asked if I would share a quote or something that I want towards the end. And one of the things I would say is that um, as a family doctor, the key thing is that when you do something for your patient, you want to see those end results, right? The end results means either the weight loss or their diabetes getting better, or their heart failure is getting better, or their depression is getting better. You will see the change in the patient lifestyle from what they started to how they ended up. That transition, you had something to contribute. It's almost like an award every single time when you win with each patient. You don't win with all patients, right? It's a hit or miss. You have some good ones and you have some that will not listen to you, but it's a work in progress. So that's what I want to share. Let me talk about a few questions here. Can the metformin and Invokana co-interact, or can there be side effects by using the two together? No. So you can use them together. You really have to be careful if their kidney function. So there are key things you look for with Invokana. It is the kidney function. As long as your kidney function is above, their GFR is above 45, you can use them. But let's say if the patient becomes sick and they're very dehydrated, you have to be really careful with Invokana because it can put a patient into DKA, which is diabetic ketoacidosis, where the patients need to be hospitalized and they need to be on insulin drip to reverse the process. But I have combined metformin and Invokana together. I have noticed that you have brought up the preference of female patients requesting female doctor throughout the presentation. Is this common? Has this been an issue at times? Okay, so here's the thing. Not all. So majority of the female physicians likes to have a female doctors for certain stuff. For example, the gyne, for example, or when they have mental health issues, sensitive topic like miscarriages, infertility, certain topics, they feel like they are more able to open up and talk to the female physicians than male. But that doesn't mean um, there are other patients that feel equally comfortable talking to the male doctors. It's just the patient's preference. But in my practice, I have had patients ask if I would do their gyne because I'm a female doctor. They feel comfortable coming to me with a problem for a vaginal discharge or having me do their PAP. So that's something I heard with my practice, but that doesn't mean that exists everywhere. It's really a patient's preference. What are the negative side effects of losing weight very quickly? So she did not lose, for example, yeah. So that's a lot. She did not lose 30 pounds in a month. She lost 30 pounds over 6 to 9 months. So that's almost close to a year. She's still coming to that 30-pound weight loss. You do not want to lose weight really quickly because you will rebound back. And it also matters how are you doing the weight loss, right? For her, the weight itself, like if you're talking about my patient specifically, her weight wasn't really the fat weight because she also had a lot of leg swelling that was contributing to her weight. So depending on the medication, the fluid came off, that also dropped the weight. The diet and exercise helped take her other component of the weight, and that's what add up to the number I was talking about. But you never want to lose a high amount of weight in a short span of time. It doesn't work. You will rebound back. And what is diet really? Like for diabetes, I understand they have to be under carb counting and portion control and all of that. If you're someone who just wants to lose the weight, just eating healthy will help you, and making very small changes in your diet will help you lose the weight. Side effects of quick weight loss. There's a lot of health factors. It can affect you mentally, right? It can also affect your metabolic system. There's a lot of things, and you can only answer this individualized depending on the patient history and what is the reason they try to lose that much weight and what kind of diet they use to lose that weight. All of that will contribute. Do you think plant-based diet can help reduce your changes of getting diabetes? So even when you do a plant-based diet, what matters is the carb, right? Because even in plant-based, if you eat chickpeas, um, there is the carb portion of it. You have to be controlled. But overall, cutting the processed meat or the added preservatives into the food will help you in terms of healthy eating. Um, I personally do like to change myself, but I don't think I can because I like meat. But I am trying to cut down. But overall, it could. But for diabetes, what matters is your carb. So regardless of plant-based or if you eat meat, is how much carbs that you eat matters. But if you choose to do plant-based, there are studies that show your overall health is better with plant-based and less of the preservatives or added preservatives or meat in general.
Thank you so much, Dr. Raj, for taking the time to answer all of our questions and for such a wonderful presentation. We really appreciate you taking your time to do this with us today.
No worries. I hope I went through
And
all the questions. I thought I did, but yeah. If any of you are still here watching, I do a lot of educational posts. I do my motivational post on Caribbean Medical School or residency matching. Any post that people usually ask me, I really don't have an agenda of what I'm going to do per each day on my Instagram. So if any of you like this kind of talk, this is the kind of way I do my post also. There is a video on diabetes that talks about type 1, type 2, and gestational. And I also did post on gestational diabetes, type 2 diabetes itself. I haven't talked about type 1 yet. And I also shared my experience with gestational diabetes and how I monitored my sugars, how I gave myself insulin, all of that and more. And I also do share my exercise and fitness that I do daily if anybody is interested in motivation to work out. I don't do that all the time. I've been off of it for almost a month because of the winter, but I try to share pretty much my life as a mom, as a doctor, and as a woman, the whole deal on Instagram. So if any of you like to follow, you can do that. It's dr. Thivisha.raj on Instagram. So if you guys have any questions, you can message me there. But yeah, it was fun chatting with you guys, even though I can't see all of you.
we really appreciate it. Thank you so much. And
No,
to all our viewers, make sure to check out the description to this video. Dr. Raj's Instagram handle will be plugged in there as well. And for everyone watching, thank you all for attending. The Google form is now in the chat box and will be in the description shortly. And just a quick update, this coming Friday, we will be starting our February roundups. So every Google form for the month of February will be reopened at 11:59, February 26th, and close at 11:59 p.m. Eastern on February 28th. So during that window, you can watch any past session from the month of February and fill out the forms to receive credit. So for more news and updates, please head over to our Instagram at WebShadowers. And that's it. Once again, thank you so much, Dr. Raj. We really, really appreciate it.